Welcome everyone to the April 27th COVID-19 clinical care rounds focused on emergency medical services, patient care, and operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds is peer-to-peer real-time sharing of COVID-19 EMS challenges and successes in patient care and operations. If I'm an EMS clinician preparing to care for many COVID-19 patients, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated, these rounds are not intended to be redundant or replace organizations' initiatives. They are intended to be sharing of clinical experience, but not recommendations or guidance. These ECHO clinical rounds you are participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. I'm anxious to hear from our speakers, and I know announcements can be tedious. But as the virus isn't stopping, it's really important you're aware of some of the critical upcoming webinars and rounds. Some of those are from our colleagues at the National Emerging Special Pathogen Training and Education Center. We appreciate their support for these rounds, and in a few moments, we're gonna announce a couple of those upcoming rounds. So for upcoming ECHO COVID-19 clinical rounds, currently, they are all US noon Eastern time. Tomorrow, Tuesday, April 28th, noon Eastern time, COVID-19 clinical rounds on critical care. We'll be hearing from an intensivist from Chicago and an update on what's changed with critical care of COVID-19 patients from our Atlanta and Minnesota speakers who presented during our first clinical rounds on critical care on March 24th. Thursday, April 30th, noon Eastern time, we'll have clinical rounds on emergency department patient care and clinical operations. So the pattern is Mondays, if it's Mondays, it's EMS, Tuesdays, critical care, Thursdays, emergency department. We are also working to have a special session on long-term care facilities, tentatively scheduled for this Friday. As you know, we do these rounds just in time. Just like the virus is just in time, we're tracking just in time. So when we send out announcements for upcoming rounds, at times you'll see speakers to be determined, since we work to identify those speakers just in time given the rapid changes in experience with COVID-19. For the ECHO clinical rounds we've had to date, we've had participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. The disease ignores no boundaries, and it's gratifying to see clinicians from across the globe learn from each other, always focused on the patient. We continue to be interested in making this more interactive by engaging expert discussants and consultants and crowdsource polling. We received many pages of questions and apologize in advance, we're not able to answer all of those. So we've picked out some major themes and we'll try to ask questions from those major themes. With that, I'd like to go ahead and turn this over to Dr. Bruce Struminger for housekeeping.
Great, thank you, Rick, and welcome again to all our participants. There are over 600 people who have joined today, and to all our expert discussants and our presenters today. So a few quick housekeeping items. There's a Q&A function at the bottom of the Zoom window. Please put your questions and comments regarding today's topics and the presentations there. We're also going to be asking you a question that we hope you can reply to in the chat. And also, if you have any questions about technical or logistic issues, please put those in the chat. This session is being recorded and your attendance is consent to be recorded. Thank you for that. The slides and a link to the video recording will be shared after the session via email with everyone who registered. They're also available through our website, a page that has all the recordings of the past sessions and all the PowerPoints. They are also in the announcements that go out. So look at those for following up with the materials. We will be offering CME and other continuing professional development credits through the University of New Mexico. There will be a link in the chat at the end of the session, and there's a link in the most recent email announcement. That's how we love giving you CPD credits, and we love getting your feedback through the survey questions to help us improve these clinical rounds. With that, I'm gonna share the microphone with Sharon. Do you wanna talk about the NETech webinar series?
Yes, thank you, Bruce. Hi, good afternoon, good morning, everybody. My name is Sharon Van Aersdale. I am the Program Director for Emory Serious Communicable Diseases Unit and the Director of Education for the National Emerging Special Pathogen Training and Education Center. We're really happy to be collaborating with ECHO on these clinical rounds and producing some deeper dive webinars based off of comments and content that we get off these clinical rounds. So we do have 2 upcoming webinars this week. One is on ethical issues in pandemic response, so triage and beyond. The other one is the use of proning, implications for your patients and your teams. And this is really looking at clinical care across the continuum. So please check out netech.org, and you'll be directed to training and education, and you can register for those webinars there. And then you also see recorded webinars from previously held webinars.
Great, thank you, Sharon. And Rick, back to you.
Thank you. One of the things that we have made sure people are aware of is the AAMC, Association of American Medical Colleges, as a clinical guide, a COVID-19 clinical guidance repository. As I mentioned early on the rounds, these rounds are not about recommendations or guidance, but also realize people want those kinds of resources. And this repository is one of those I would encourage you to take a look at. Now, on to your work as participants. It is extraordinarily helpful to get responses to these questions. We actually not just take a look at them, it helps guide our how we select future speakers. It helps guide these rounds in many different ways. So the crowdsourcing question, in the past 7 days, what is the best operational change your EMS system has made in response to COVID-19? In the past 7 days, what is the best operational change your EMS system has made in response to COVID-19? Realizing many have made a lot of operational changes, but what's been the best one you've made in the past week? And then what state or country are you in? So with that, I'm going to turn this over to our first speaker, Mr. Jim Hooley, Chief of Department, Boston Emergency Medical Services. With over 35 years of experience at Boston EMS, Jim Hooley rose through the ranks of the department, selected to serve as chief of the department in 2009. Through his leadership, Boston EMS has stood up heightened awareness and responded to large-scale incidents such as the Boston Marathon bombings, H1N1, and SARS. Chief, it's an honor and a privilege to introduce you, sir.
Thanks, Dr. Hunt. Can you hear me? Okay. All right. Good to go? All right, thanks. Here, let me just share the screen. And then Control L, right? Sorry. Let's try this again. That's better. Okay. Let me just get back. So just minimize the video here. And if anybody can't hear me, please let me know. I don't have the greatest speaking voice, and people often tell me they can't hear me. So anyway, thank you for inviting me. It's really it's an honor to be with all of you there and a chance to talk to anybody else from other jurisdictions, other parts of the country, because I'm eager to learn from them as well. We'll just start off real quick. So Boston EMS, give you an overview. We're the city's emergency ambulance provider. We're the 911 provider for the city of Boston. We operate a two-tiered system. We operate ALS, dedicated BLS, dedicated ALS, call types when they're entered by our dispatchers that follow APCO EMD guidelines. For police headquarters, the call type generates the response, whether it's ALS, BLS together, which ones automatically go to police and or fire dispatchers or both, because we all share the same computer-aided CAD system. Boston is a resident population of about 700,000 folks. Service population is 1.2 million. And it's actually, usually it makes it for a little bit busier than we've seen the last few weeks, because with that in mind, typically with this service population is really up because of the busy transportation, the financial centers, all the businesses and trade, the sports facilities, the venues, the hospitals themselves, which are probably the biggest employer in the city of Boston as well. So it's with the shutdown and the ban on all but essential personnel, that has kind of slowed down that service population. Traffic has never been so light here, but I've gotten to the point where I miss my traffic jams. Before COVID-19, our typical peak deployment during the daytime would be 22 BLS and 5 ALS ambulances. For the day and evening shift, we have a period between 2 a.m. and 6 a.m. where we kind of, that goes down to by about a third, but it's picked up since then. What's that again? Technical. Stop sharing. Okay. Well, I don't know. Was that not going through before?
Yeah, I think we know.
Oh, okay, the wrong one. Anyway, okay, sorry about that. So I'm new to this part as well. Well, so anyways, we had our total call volume last year was 127,802 clinical incidents, and you can read the numbers. I don't have to do that, but like almost 160,000 responses, and nearly 87,000 total transports. We have a full-time workforce, 425 full-time employees, and about 390 of them are uniformed EMTs and paramedics. And why won't my slide advance? Okay, hang on. There we go. All right, the current situation. In Boston. And this was current as of the 25th, so those numbers have gone up a little bit. I think we actually hit the 300 mark on deaths today, I heard. But we had over 7,900 people who tested positive for COVID-19. And over 50% of Boston's hospitals' ICU beds are occupied by COVID patients, and which this morning, I believe, was 540 of the ICU beds in Boston are occupied by COVID-19 patients. And that's with 432 of the ventilators in Boston, beds with ventilators, people getting ventilator support are COVID positive. We've had over 19,000 Boston residents tested. And in Massachusetts, I know they've had over 51,000 total cases. And that one graph at the bottom shows you our daily transports going back to March 15th. March 15th is when the activity started picking up here, when a lot of the practices, school closures, and different things started to go into effect. Our call volume dropped down below what I reported out earlier. And the bar on the bottom was the number of percentage of calls that required, where we either notified the crews in advance to don PPE because of information received at the time the call came in, or from information received once we got on scene. So the percentage of calls that required full isolation precaution for droplet. How we got here. So February 1st is when we had the first confirmed case here in Boston. With that, there was a cascade of effects. The situation did escalate quickly. It involved daily and regular briefings from the CDC, development of guidelines. We began issuing infection control guidance to our public safety partners. Everything that we put out to our personnel, we made sure we shared with police and fire, so we'd all be on the same page because we all go to many of the same calls. The photo there is the Eagle Room down at the Boston Mayor's office. And as you can see, that was back around February 1st. So no mask, plenty of people in the room, no real social distancing evident in that photo. Some of the key dates, the city declared public health emergency on March 15th. The 17th, all Boston schools were closed. And by April 1st, you can read the numbers. And then by April 10th is when they opened up Boston Hope, which is a field hospital that's licensed through Partners Healthcare. It's 1,000 beds. 500 of the beds are actually hospital patients who are stepped down, perhaps not ready for discharge, but they're able to be admitted and cared for there, which freed up a lot of the hospital space in Boston to be converted to for ICU capability. And that was probably one of the best things that this region did in preparation for the surge. The other 500 beds in there were more respite to deal with the population of undomiciled or homeless persons that we have in Boston. There are several homeless shelters. And when that congregate setting, when you started seeing positive patients, you needed a place to separate them from those large shelters. And that quickly became that need was present. Okay, so the planning and preparation continued locally in our department. Again, if you look down below, that's a conference room on our floor. That photo was taken on February 2nd, again, before all of us in headquarters and dispatch and everywhere else routinely wear masks and get screened coming in and out. We had decades of planning and emergency preparedness efforts that included training and exercises. We had started stockpiling supplies and equipment. Some of that did go back to the days of SARS and MERS when we followed the experience in Canada, which that really affected SARS, some of the EMS personnel up in Toronto. We tried to learn lessons from them. H1N1, a lot of our folks, we went out and ran flu vaccination clinics as well. So we were a little bit used to the drill, but we weren't prepared to see the extent of illness, however, in the community. So we had to ramp it up. And then we've established a pretty good healthcare system coordination across Boston, where the physicians like Dr. Binger, who's on this panel, we all know each other. We've all been through many different tabletops and drills and exercises going back, whether it was for the Democratic Convention, after the terror attacks, up to the bombings. Back in 2004. We tried to meet regularly and coordinate for events. And on our side, we quickly decided that the main things that we had to prepare for were personal health and wellness, patient care in these settings, and to be ready for the medical surge. So the personal health and wellness, a lot of questions about PPE. We'll start off with that. The photo you see there is, typically what our folks would dress up at when they're handling a patient who we suspect of having COVID-19. Gown, gloves, face shield, N95 mask. Everyone's been quantitative fit tested to make sure that he or she is wearing the right mask, and also the head cover and the boot cover. That's required anytime they're going to be getting in close or carrying or assisting down somebody who we suspect of having it. if you're doing any sort of airway management, any sort of resuscitation, then anybody who's going to be at the scene has to be dressed up. Supervisors or assisting crews, anybody who gets in the back of the ambulance has to go to that level. Other than that, our baseline is a surgical mask, just even routinely now on a call or riding in the truck with your partner. As soon as you get out, you have to have a face shield on going to every single call, and of course gloves, with the idea that you have to then like take a step back and throw everything else on if there's any reason to suspect it. And pretty much that's at least 50% of our calls now. We do have to do that. We did a lot of training on donning and doffing to prepare for that as well. That required us to calculate our burn rate so we could report to the city and our materials management to make sure that we're going to have enough to sustain our operations. One of the things the mayor told us when we first sat down on this, he said was, if you're not prepared to sustain this through July, then I submit to you, then you're not prepared. So that was some pretty clear marching orders for us. Source control, that's also became very important. We started early on putting a mask on every patient, whether they were symptomatic with a cough, fever or not. If you were injured in a bicycle accident, you're getting a mask. You don't get a chance to do the call over again when you found out later that this quadriplegic guy who hasn't been out of his house in years, who hasn't been to Italy, hasn't been to China, who's got a fever, turned out was COVID positive, and you maybe thought he had some other infection going on. We learned some lessons the hard way the first time, and we incorporated that into our standards. An infection control program to try to keep as many of our folks online and to stay on top of any potential exposure and to make sure they were getting good care. We brought on a full-time physician into our department. We're fortunate. We have a medical director, an associate medical director, and a fellow who are full-time for us, and they all serve as our designated infection control officers. But we also brought on 3 nurses full-time to help us do contact tracing and follow-up. We also brought on back from retirement, who recently retired, a doctor who was the infection control expert in the city of Boston for over 25 years. And we have her working in with us to help with that. That's paid big dividends on one, trying to keep our people confident and calm, having that expert resource here as well. And also they're available to consult with family, because a big thing is having people who, it's one thing to put somebody off for 14 days because they may have had a contact to a highly suspicious case without protection, but they're worried about who's at home, and now you have somebody who can be a real resource to help with that. And the last piece in that was housing. The city of Boston did develop, in response to our request, they provide dormitories for our members, anyone who's like just doesn't want to go home because they're afraid they have somebody at risk at home, or maybe a family member, a grandparent who's going through some sort of treatments and maybe immunosuppressed. But also we have a hotel where one member is actually, who's positive, who's actually recovering right now, is staying at that and being tended to because of, again, the situation at home, that he did not want to cause problems there. Patient care, at 911 early on, we started, that typical call screening that everyone was doing, travel history, first to that city in China, then to the region, then anywhere in China, and then the other countries as they got added. But that quickly became useless when the cases started popping up here. The travel history really didn't have anything. Then it was only to screen every single caller for potential that they had any kind of signs and symptoms, any known exposure, or had been told they had a family member exposed, and just trying to control for that and alert our crews so they would go in dressed up for the beginning. Because like I say, you don't get to do the call over again. We want to make sure we take every precaution going in. And eventually we did wind up pretty much assuming that every patient had COVID-19 until proven otherwise. I standardize our post-transport infection control and cleaning, and limit the number of providers at a scene in the truck. We don't put any more people in than we have to. We would stop taking riders, in the ambulance. First of all, when they get to the hospital, they're probably not going to be allowed to go in. Obviously, if it's a parent or a guardian of a child, we would, but you put a mask on that person, you put that person in the front. The next thing was to try to, on our patient care practices, to reduce the chance of transmission when you really have to get up close and personally taking care of somebody. And that included the installation of HEPA filters on all our bag valve masks, making sure that Boston Fire Department had HEPA filters for all their BVMs because they utilized them as well. We were able to obtain MDIs in chambers. So instead of using the albuterol and the Acorn nebulizers, which can really produce a lot of aerosol, we wanted to limit that. So we went out and we got those other devices. A few other things too, drape, a clear plastic drape sheet that gets placed on somebody who's having their airway, who's being intubated, to try to help minimize any kind of splashback for the paramedics when they're doing that. And we also, our medical director did authorize the process of doing CPR with the high flow, either nasal or oxygen in a mask, underneath the mask for the first 8 minutes of a resuscitation, until such some time that the person can be intubated, or we go through the defibrillation and other steps. Again, with the idea that to really try to control sources of infection at the scene. For medical surge, our planning then quickly broke down into two ones. One was to meet the anticipated rise in demand for services, then the other one was to reduce the demand on services. Obviously, to increase it, it was to reassign all able-bodied personnel up to the field. Extra supervisors out, pull people out of our training division, pull people out of other areas who could staff either a supervisor or those trucks. We suspended our recruit academy a couple of weeks ago. They were only halfway done. And what we did was we used half of them up in dispatch to help us with call taking, clerking, and staffing, which is very demanding. And but most of them were assigned to Victor units, which are just vans with autoclaves, cleaning materials, high-level disinfectants to augment crews who are already doing that at hospitals, but to kind of jump in where they can and try to. We do that from 6 in the morning till 4 in the morning. They try to hit as many trucks as they can to help the ambulance crews do that. And then 1 day a week, they rotate through and they hit the different stations to try to do that for us as well. Reducing the demand, one of the key things we tried to do was introduce telehealth by way of medical consultation with emergency medicine physicians from Boston Medical Center. We currently now have about 14 of them signed up, and they do take call. It's working today. The cases must meet a criteria of being low acuity, but they're not just for COVID patients. We had to do a bit of negotiate to get that through the state. The idea was that if you had the toothache or something else where you're probably not going to serve that patient well going to an emergency room when 3/4 of the people in there have COVID. Some of the ways to redirect them are some things that those physicians could do. Because in Massachusetts, we have an obligation right now, the way the regs are, you have an obligation to dispatch an ambulance if somebody calls for 911, and the obligation to transport them unless they sign a refusal. And so it's push comes to shove. It's kind of hard to say no to somebody, even if it was for something that would seem as trifle during a disaster as that. So, and in many cases, some people were calling because they were young and healthy, and they suspected they had it. Maybe they're looking for testing, so that the docs could hook them up with
places nearby them, that we can clear those calls off and not have to dispatch them at all. The other thing is the crews in the field are also trained to contact the physicians if they encounter a call like that. Maybe they can get a disposition in the field and save us from having to dispatch resources. So let me try to wrap up quick. I think I went over my 10 minutes, but so the successes on the personal protective protocols, I hesitate to say great success. I will tell people on this call, we've had 11 of our employees, our EMTs and paramedics, test positive for COVID-19. 7 of them have returned. They've fully recovered, and they're back working on the street again. 4 are still out. I expect 2 of them to be returned shortly. The 2 of them are having some lingering issues with some mild respiratory symptoms. 2 of them who are also asthmatics. None of them were hospitalized, thank goodness. The Boston Police Department has had many times that number, and I'm not sure the exact number for Boston Fire, but I know it's more than us. And Boston Police actually buried a 49-year-old officer 2 weeks ago from their drug control unit who succumbed after being in the ICU for 2 weeks. So we're trying very much to stay on top of using the doctors and being really good about enforcing the PPE protocols and personnel. That robust infection control program, we're really investing in bringing on the nurses and the doc to help with that and to help with a lot of the anxiety that this situation is causing us. The call screening, the early identification helped a lot. So crews already had an idea what they're walking into before it became obvious, just watching the news now. The adjuncts to minimize disease transmission at patient care, I think, help. Handing patients off at hospitals. There's like 11 hospitals in Boston, 8 of the ones that we routinely are transporting to. Each one had their own policies and procedures for accepting patients coming in, and they did not exactly all adapt and jive with how we were telling our personnel. So we did walkthroughs at every single hospital, and we ironed out all the issues so that they went smooth prior to the surge, so that we haven't had any issues since we ironed those out. And the pre-hospital telehealth, that end of it has really helped us. The challenges, screen out of the way. Adapting our response operations for the foreseeable future to respond to COVID-19, as well as the normal 911, as the city starts to reopen, as entertainment complexes, jobs, everybody needs to get back to work. I understand that. At some point, we are going to resume the normal. The call volume is going to go back up again, but it's we're still going to have cases out there. We're still going to have to be able to screen for them if we want to keep our personnel safe, and take good care of our patients. So it's going to come with some heightened monitoring as we try to shift back to normal. Sustaining this heightened response posture is difficult. It's draining on veterans and on new people. Every day, the big question is, when is this going to end? And it's trying to keep people's spirits up and keep them in the fight. It requires a lot of communication on our part. Maintaining the necessary levels of personal protective equipment. We probably have about 10 more weeks of N95 masks before we run out. We're going to start recycling. We're cleaning them through an arrangement with partners in Mass General coming up. And then finally, personnel retention. We have had one person that retired a week ago. He could have stayed till June and actually got a little bump in his retirement by a couple $100 a month. And he said, "I don't need the money that bad. I'm done. Thank you." Now, he might have had some health issues or something at home he was worried about, but I wonder what that's going to do to EMS a year or two from now. But what it's going to do for our recruiting. But I hope in the long run it won't impact us. Then there's finally finances, because we're all
Everything you see here costs extra money, and when you're transporting less people, you're recovering less third-party billing. So that's all I have. Thank you.
Chief, thanks very much for your presentation. Obviously, the vast amount of experience I'm sure has been very gratefully received by the participants. For participants, there are 776 of you, 775. I need to tee you up for a couple polling questions. They will be up for 30 seconds. As soon as we can get that first polling question up, I'll read it, and if you can be quick on your responses, we'll keep it up for 30 seconds. Go to a second one that also will be up for 30 seconds, and then we'll go to Dr. Gallagher. First polling question. In the past 7 days, are patients being seen by your EMS system sicker because they've delayed seeking care? So that one,
Yes.
on 30 seconds starting now.
All hosts? Oh, can I vote?
15 seconds to go. Apparently, I've been informed the host and the panelists cannot vote, so there you go. All right, done. Second question. Over the past 7 days, is your access to PPE while caring for patients, I'm not talking about the supply chain and how many's in the warehouse, is your access to PPE while caring for patients better, worse, or the same? Go. And about 15 seconds left. And Bruce, if we can get the results up, we'll display those, and then we'll get back to Dr. Gallagher. All right, 52% of you say the patients being seen by your EMS system are sicker because they've delayed seeking care. 52% said yes, and it turns out that on April 10th, when the same question was posed to this same type audience, EMS audience, it was 64% yes. Over the past 7 days, is your access to PPE while caring for patients better? 22% said yes, 10% worse, 69% the same. And I don't have the ones from the most recent one from that, but I think that's not far off from the previous one that we have. So thanks very much for that, for doing that. And a lot of responses. Really appreciate your doing that. Helpful for all of us to see what's going on in the nation. With that, I'm going to move to Dr. Gallagher. If we could get that screen off. Dr. John Gallagher. Dr. Gallagher is the Service Director and Medical Director for the EMS system of the City of Wichita and the surrounding Sedgwick County. He serves nationally on the Board of Directors for the National Association of EMS Physicians and at the state level on the Kansas Board of EMS Physicians Advisory Council. So, John, please.
All right, let's see if I can get this squared away. We should have both audio and video. Rick, are we good?
Great, yeah, absolutely. Two thumbs up.
Fantastic. So my name is John Gallagher. I'm a EMS and emergency physician. And I have a somewhat unusual circumstance here where I'm both the service director and the medical director for our system. So I'm going to be speaking from a slightly different perspective than some. Just real quickly, no conflicts, but a couple disclosures. We'll leave the speaking for NAMSP to the good Dr. Tan, and I'm certainly not speaking for the state board today. So perspective, I think, has been one of the biggest lessons for me lately. It just seems that people are going through very different experiences surrounding all of the COVID issues. And I think it's resulting in people making different decisions and even having some conflict when perhaps maybe they're both right, just based on different circumstances. So I'm going to speak to a slightly different situation than what we've been hearing a lot about. So I live in Kansas. So for those of you on the coast, that's one of the big flat ones in the middle. And we have not seen the caseload that a lot of the other communities that have been more prominently featured in some of the reporting. And even within our state, where that's where we're located, we're seeing a relatively low number even within our geographic area. So a little bit different. We're certainly in the game. I mean, this is the data that we've been tracking in our system, and we've got a bunch of cases, and we do have a smaller population, so it is meaningful and it has changed the way we're doing things. But it's definitely not the perspective from New York or even Boston, our previous presenter. We've got a steady climb in cases. It seems like this reached our community a little later than others. But we're also starting to see an increase in the number of recoveries, and you know, our systems are doing pretty well to take care of people. And for better or for worse, one of the things that happened in our community was we ended up being a very low testing community. So this shows some of the testing rates based on population that have happened throughout the country. And we're in one of the lowest areas. And I'm not advocating for that being better or worse, but it's the experience that we've been in our community. When you look at that across the other states, there we are, sort of towards the bottom. We beat out a few, but that's the approach that's been taken. And again, I showed this once before, even within the state, we're a fairly low testing county. So this has given us a little bit of a different perspective on how to manage the COVID scenario. And I think there were a lot of reasons around this. Some of it was intentional decision making. A lot of it was availability. So our system has two major hospital systems, and both of those are major national players. And for all the right reasons, early on in this, a lot of the resources were being sent to their areas of the country where testing was deemed to be more necessary or more urgent than what we've had. And so early on, we just physically didn't have access to the tests. And a lot of our behaviors and some of the decision making that we had was altered by that, and really built around how are we going to provide care in the community without this particular tool being widely available. And it doesn't mean that we haven't had any. In fact, we've done a whole bunch of testing, just over 25,000 as of a day or two ago when I pulled this slide. But not surprisingly, they have been in the categories of the ones that are more substantial or higher risk, people that the treating clinician really felt that we were having a higher probability that this person was going to be positive. So we did those 25 tests, and of those, we've seen a little over 3,000 cases. Which tells us that of these people, this cohort of high-risk patients, we're seeing about 12% of those being positive. And I think that's interesting because even in that group that's been selected as much higher risk, pushing 90% are still coming back as other diseases. So enough of the epidemiology stuff. We have been asked this many times, and we were asked it for this presentation, is, you know, what's the biggest challenge that your EMS system is facing? Well, before COVID happened, this is what my system looked like. These were the call types that we had. We did a lot of hospital transfers and a lot of sick people and all the things that you guys probably also do. And I would suspect that if any one of us ran this same graph on our services, we would probably see pretty much the same shape for the overall service. And we asked ourselves the question, okay, well, now that so many things have changed, with COVID, what's the new graph look like? And I don't know if this will surprise you or not, but it's virtually identical. We are in fact doing essentially the same job out there. And yeah, people are going to the hospitals less often, and so the hospital transfers have dropped a little. And we are seeing people call in for a proportionally higher number of sick people. And some of these are just increased because we've had a decrease in overall call volume, so the percentages have changed. But if you look down at the bottom, we're working in single-digit % changes here. So from a scientific standpoint, it would be difficult for me to say that this had changed in any way. So one of the biggest challenges in the way I'm answering the question today is it's been continuing to care for all of those patients that don't have anything to do with coronavirus. And even when I look at the most common causes or the common symptoms of coronavirus, most of the patients that I see with these various chief complaints aren't going to eventually be diagnosed with COVID. I suppose if somebody had all or most of these, that's probably a much higher probability. But for any one of these given complaints, we're seeing lots of focus and lots of concern around COVID, but it's not necessarily what that patient actually has. And I think it becomes very important for us as system supervisors and medical directors to make sure that we're not allowing our other patients to be harmed because of all of the focus that we have on this. And we did see some of this. So this is just a screenshot from earlier in this month where our partners in the cath lab, or interventional cardiologists, were struggling with what they should do in all of this. And unfortunately, in a lot of systems, it got to the point where primary PCI centers had started moving away from using the cath lab, a time-tested and proven superior option, and reverting back to using thrombolytics for STEMI patients. Now, fortunately, and credit to them, they were able to get that moved around and have just recently put out some guidance that that's not what we should be doing. We should continue to deliver the standard of care. But the fact that the conversations happened and has exposed several communities to this type of decision-making, I think is concerning and warrants some conversation. This even happened within the American Heart Association. Never before have we seen, or certainly not in any recent times, the AHA come out with guidance that prioritizes intubation for cardiac arrests. And we certainly haven't ever seen a bullet point that suggests that we pause chest compressions for intubation. So for those of you that have been around in this game for a while, it feels like a dramatic departure from where we've been. The hospitals are seeing this for sure. Patients are terrified of going to the ER and are now having to reach back out to people to explain that some things actually are emergencies. It's still something that you need to call 911 for and you need to get into the hospital. But we've seen a major change away from this normal healthcare, even though the vast majority of our patients are not coronavirus. So what do you do about this? I think it needs to be agency specific. What we did in my community is we just started speaking to it. This is just a snapshot of a message that one of my deputy directors sent out to our crew, just speaking to the issues, right? And she mentioned specifically that the vast majority of these cases aren't COVID. And I don't want this to be misinterpreted as we shouldn't be doing all of the right things and taking the precautions. And my system certainly has. We've done the PPE, we've revised our infection control policies. We've even switched from the N95s to the reusable full face mask P100s. All of those things are appropriate and all of those things should be done. But that's only a part of our mission for our various communities right now. And I hope that we can continue to focus on that. One final point, I would be remiss to not mention this as it's come up in several conversations, is this concept of the crisis standards of care. I think we've all been in this mindset of what do we need to do when we are overwhelmed and inundated and loss of staffing and materials and PPE. But I think most of us aren't actually at that point. Some of the cities have been really hard hit, may have reached that point. Some may even still be there. But I can tell you that my community definitely does not qualify for crisis standard of care. And my suspicion is that many of yours don't either. So it's important for us to remember that we will still be held to an expectation of the normal standard of care. And the good Dr. Kramer will be happy to see this in any presentation. Just a reminder to people that when we're working under normal standards of care, we do need to have all of the components from the National Scope of Practice model. And the portion that we've been working in is this seldom talked about Region D. I put up a QR code if you want to read the details on this. But most of the unusual policies and behaviors that we've been implementing in the coronavirus pandemic have fallen into this Region D. And that's areas where the state is allowing us to practice these different behaviors, and the medical directors are credentialing people to do it. But it's important for us to remember that the Area A of education, none of our providers had education on coronavirus for this. Most of them did not have any education on things like leave at home policies or changes that we may be making. And certainly nobody has gone through certification testing. There are no coronavirus questions on the National Registry exams. So between the state licensing and the local medical director, we really need to make sure that we're still following these same components. So stuff that I didn't expect to learn in 2020, real briefly, is number one, there really doesn't seem to be an answer about testing. People are back and forth on this, both sides of the issue, and we've got smart people on both sides, so it seems to need to be a community level decision. Number two, while our focus has been on COVID issues, this is only affecting a fraction of our patients, and we need to make sure that we don't allow that to harm the other patients that we see on a day-to-day and hour-to-hour basis. And finally, even though this is occupying 100% of the spotlight, we do still need to meet the normal standard, unless, of course, your community has qualified for a crisis standard of care. So if there's any questions, I'm happy to take those. I'll turn it back over to Rick.
Thanks very much, John, for your presentation. We could yeah, perfect. Like the Hollywood Squares. Great, wonderful. One specific comment about your presentation around the crisis care piece, which is been on the minds of all of us in healthcare. You know, there's an academic construct of crisis standards of care, but there's also concepts of preserving, conservation, and that academic construct many would call contingency and so forth, so on. So it's sort of a continuum. And one of the things that I'm particularly grateful for your presentation about is that, you know, people talk about, well, it's coming to the heartland. And I would say Kansas, that flat state with the multiple counties, certainly kind of like is that heartland piece. And your experience and others across the nation are going to vary considerably. So appreciate your presentation greatly. Okay, so a specific question that came up. Need 2 seconds here. Oh, before I go to the questions, let me introduce the panel. For the panelists, if you could just like unmute yourself, and I'm gonna like point to you really quickly and ask you to introduce yourself, just name, title, and your affiliation. Sharon, you already had your introduction. Paul.
Paul Bittinger, Director of the Center for Disaster Medicine, Mass General Hospital in Boston.
Rob.
Hi, Robert McClintock. I'm the Deputy Director for Fire and EMS Operations at the International Association of Firefighters.
Doug, then Alex, then David. Doug.
Doug Kupis. I'm a member of the NAMSP Board of Directors, and I'm a EMS physician at Geisinger Health System in Central Pennsylvania and the Commonwealth EMS Medical Director for Pennsylvania.
Yep, thanks, Rick. Alex Isaacov, emergency medicine and EMS physician at Emory University in Atlanta and the lead for NETEC on EMS issues.
Thanks. And before David, Ed, if you want to go off mute and introduce yourself after David. David.
Hi, Rick. David Tan, EMS Chief at Washington University in St. Louis and President of the National Association of EMS Physicians.
Thank you. Ed, if you're able, if not, we'll move on. All right, thank you. So we're like 5 minutes before the hour. We'll go till 5 minutes after the hour because there's some, there's some really important, not just questions, but issues that are definitely in a state of transition with our clinical challenges in EMS for sure. I want to talk about interfacility transfers and transport in general. Long range, we get questions about long range transport. We get questions about air medical care, transport. We get questions about, are you doing interfacility? Are you load balancing? And just a couple brief comments from the panelists. Each of the panelists on that would be helpful. So that's basically the topic of interfacility transfer, long transports, and also the load balance thing. Paul, we'll start with you, and then we'll go around the Hollywood Squares, okay? Just a couple comments.
Sure. I think one thing Chief Hooley already alluded to, but that really helped us with transfers and load balancing is that our system has actually all of the critical care directors plus EMS, Chief Hooley's represented there, come together every single day to talk about the relative ICU capacity of the hospitals. Several of our hospitals, my own ICU included, are about 3 times capacity, what we would normally be. And so we've been talking about, broadly speaking, how to collaborate to share directional arrows so that each of us actually directs some of the transfers, especially on the long haul ones, to one another, even if we're not part of the same system, just so that nobody gets overloaded. It's been a good collaboration between EMS and the hospitals.
Thanks. Rob?
Yeah, so a lot of the interfacility work that we've seen with a lot of departments have actually, they've been reduced, somewhere between 30 and 40%. They're losing volume on interfacility just of the fear, I guess, of people, moving people from nursing homes and so forth. So we've seen a big reduction.
Okay, Doug?
I think within my own system and across the state, I think the health system that have transfer centers have really stepped up, and we've seen a great resource there, because most of our interfacility transports are recorded or are coordinated through these health system transfer centers, and they are using specific EMS agencies that are doing a lot of those long distance transfers. So that coordination, I think, has helped a great deal in keeping many of our agencies available to their communities while the transfers are coordinated. I saw a couple questions about PPE and things with long distance transfers. I think really the principles are the same. Everybody should be using, to me, the biggest point to all of this is appropriate PPE use. And whether you're doing a short 911 call or a long distance transfer, it really is being fastidious about the PPE use and certainly continuing it through the entire transfer. And that's, I don't think it makes any difference whether it's a 5-minute trip or an hour trip. You just have to pay more attention to being careful about what you're touching and doing with your PPE on the longer trips.
We're just wondering whether or not Dr. Isikoff might have texted your answer to you for that one. Alex, the PPE thing?
No, sure.
The interfacility, he teed that one up.
Yeah, for sure. Well, so interfacility transfer is still critically important for our regionalized systems of care. I think John Gallagher really underscored the fact that we still need to continue to provide service for those STEMI patients, for the trauma patients, for the stroke patients, for the septic patients, those that are seeking some higher level of care. And in that context, we're going to find patients that are going to be COVID positive. I'd say my biggest point for EMS services providing those interfacility transfer services is to really be wary for patients that have COVID, because they may not have been diagnosed at the point of origin. And in addition to the PPE that Doug has mentioned, there are other things that we can do too. For example, HEPA filtration on exhaust ports of bag valves, bag valve masks, certainly HEPA filtration on the exhaust ports of ventilators when we're doing these interfacility transports. There's also a lot of interest in proning patients. Obviously, maybe better described in the critical care literature than in the EMS literature, but better aeration of the alveoli, better oxygenation as a consequence of proning. And I think as an EMS community, we may need to explore how we can continue that type of intervention if it's been started at a community ICU for patients that are going to a tertiary care center.
Great. Thank you. David?
Well, something that our region did in an unprecedented manner was to form a joint consortium of competing health systems where the Joint Command said for purposes of interfacility transfer, if in fact we need to have a specialty care, a patient that needs specialty care and one system isn't available or doesn't have it, that it doesn't matter what your boundaries are. They remove all those boundaries and all those barriers and make it available for whatever the patient needs, because as Dr. Gallagher alluded to, we have to take care of these patients. And kind of along those lines, something that Chief Hooley said that really resonated with me was that leveraging pre-existing relationships in times of crisis really pays off. So it really underscores the importance of having those relationships before something bad happens, so that in a time of crisis like this, you can really leverage that and make sure the patient gets exactly what they need, regardless of the system or hospital availability.
Thanks, David. Ed?
Hey, so we, like everyone, we've nationwide seen a decrease in interfacility transports. Interestingly, I think really beginning the tail end of last week, two concepts that are evolving with our organization. We had a discussion this morning. One is as hospitals are starting to reopen electives or starting to change specialty designation centers, patients are arriving at emergency departments where a healthcare system may take all of their STEMIs to one of the facilities in that community and not keep all of their STEMI centers active. So started to have some discussion about how to move patients who enter the system where the healthcare system hasn't ramped up that specialty service yet. So that's one. And two is, I think, as everyone's alluded to, what are the PPE requirements today? I think with our colleagues in New York and looking at the data with more broad spread testing, we're rethinking how we move that patient population who may be unknown. And essentially, I think, as most of us are, defaulting to COVID level PPE as opposed to what we've historically done.
Thanks, Ed. If we're going to do some lightning rounds questions, okay? Raise your hands in the affirmative and keep them down in the negative. So for the panelists and speakers, first question. And the context for this is a lot of discussion, even during the very first EMS rounds that we did around proning. A lot of discussions like emerging and so forth. Is your EMS system doing proning of patients in the ambulance? So raise your hands if the answer is yes.
We're not proning non-intubated patients. We are proning intubated.
Okay, all right, that's good clarification. Okay, Ed, I saw your hand raised. Okay, all right. And then the next question is, let me give you context for this one too. Lots of questions about testing. I mean, it's hard to turn on any media and not see testing be the key word right now. So the question is, are you, for your staff, currently providing in any way, shape, or form antibody testing? Okay, all right, interesting. All right, again, we're all in evolution. There's no right or wrongs here, I guarantee you. And then the last question, this is like, take your mics off mute if you would, because I just need like a single response for this, and then we'll close out. And this has to do with the handoff of patients from the EMS provider, EMS clinician, to the emergency department. What's the most important, critical piece to that you found to be the best operational change in that handoff? So we'll just go around the Hollywood squares, just like a single, one sentence answer, because this comes up in every session that we've done, and it comes up not only in the EMS rounds, but it comes up in the emergency department rounds too. The the transfer from ambulance to the ED. So, John, everybody take your go off mute. John, what's the single most important thing you think about with this?
So I think just in our system, the biggest thing or big win has been the hospitals are now listening to our handoff reports. All of a sudden, the information gathered pre-hospital is incredibly valuable. So
they're listening really carefully.
And that's great, right? You know, we've fought that fight for a long time. And I don't want to be disparaging to the hospitals. They've been wonderful partners, but their attention has gone up dramatically on both the radio and at the bedside.
Thank you. Chief?
I didn't think of that one, but I should echo that. I think one of the things that helped though too is unless somebody has to go to a trauma room, or has to go into a specialty room, the handoff is quicker, and it's closer to the door, closer to where we would be doffing, and in most cases, we're not bringing a patient to a maze of corridors to get to a bed assignment. It's the quick handoff. Which is good for the hospital, it's limited exposure, but it's also, it helps us cycle out quicker because it takes a while to put the truck back together again.
Yeah, right. Yeah. So Paul, most critical thing about the handoff of a potential COVID patient?
I think site preparation, as Chief said, we had to meet with Boston EMS to make sure that for doffing, for waste management, we met their needs and that they met our needs in terms of making sure that information didn't get lost in the handoff, but that collaboration about how and physically where the site would be configured was really important.
Yeah, it's not the handoff itself, it's that prep piece. Got it. Yeah, thanks. Rob?
I have to agree with Boston. It lessens dwell time.
Doug?
Makes the turnover a lot quicker.
Got it.
Less than wall time. I like that expression.
So Pennsylvania's always had, or not always, but has a requirement that follows the national guidelines that handoffs at the bedside, even before COVID, are supposed to be a verbal report, are supposed to have a written handoff and an opportunity for questions. And I think with COVID, with less providers from the hospital in the room sometimes, and with people having more of an interest in quickening those handoffs, there's an opportunity to lose information. So we have kept the requirement statewide for our two-minute written form to be handed off with the patient. In these times, we think it's actually even more valuable. What we have done is statewide, we have given a waiver to the hospital provider signing that form so that there's no exchange of pens and signatures and that sort of thing. But we continue to require both written and verbal handoff as part of the process.
Thanks. Alex?
Rick, coordination of the handoff with the facility is really critical. And we try, one element or aspect of the handoff is healthcare personnel safety. But I would say for EMS directors and medical directors, if you find that there's a facility that wants you to doff your PPE before you bring the patient in, where you have to re-don, doff again when you come out, and then put on another piece of PPE to clean the ambulance, that's not practical. It's not safe for your EMS personnel. I'd say you got to work, with the receiving facilities to coordinate that handoff so that it's done in a way that's safe for your EMS personnel as well as for the receiving healthcare personnel in the ED.
Thank you. David, Ed?
For us, the majority of COVID patients, thankfully, have not needed immediate airway management. A few have, and if they go to the wrong part of the ER, it can really create suboptimal conditions. So for us, the most important EMS piece of information is in that pre-hospital incoming radio report. That really all we want to know is, do you think they need immediate airway management or not? And if they don't, they can go to our standard COVID area. But if they do, then we will put them into a critical care area where we have everyone fully prepared in full PPE and ready to manage that airway immediately.
Hey, David, in the hundreds of questions that we got, that radio report thing, thank you for answering that one. That was great, because it's like how to cover all of it. So thank you.
This is easy. A unified, consistent, reproducible, don't vary, agreed upon protocol and approach with every healthcare facility, every EMS entity, so that it becomes secondhand, regardless of the provider, regardless of the healthcare system. It becomes entrenched in the practice, so nobody has to guess about how it may be different. And by the way, their family members and their ancestors as well.
Yeah, it strikes me that one thing that I think John mentioned first about, they're listening to our reports. Wouldn't that be a good thing to sustain after this is all over?
Absolutely.
With that, I'm going to turn this back over to Dr. Strominger for final housekeeping comments, and then we'll close.
Great, thanks, Rick. Final housekeeping is please take advantage of the CME and CPD credits. There's a link in the chat. There's also a link in the announcement you received, the most recent link. And it will just take 2 minutes to fill out the questionnaire, and we look forward to getting your feedback so we can keep improving these. Stay safe and have a good week.
Yeah, Bruce, it was a good reminder. I need to work with you and your staff to make sure I get my CME out of this too. I keep forgetting that. Seriously, I got to tell you, this could have gone on for more than a couple hours. Again, I've mentioned before, it's like, this is like the 3-day conference. We're trying to jam into an hour. We can't get it all in an hour. Everyone's frustrated because we can't get all this figured out right away. But these rounds, I truly believe are helping figure this out, and appreciate everybody hanging with us. Thanks so much. We'll see you on the next one. Bye.